Hello, how are you? I hope everyone is good, fine. So today the topic that we are going to study that is approach to short stature. That for example, if a child with short stature who is short that arrives at your clinic, so what are you supposed to do and how will you approach that child? So whenever a child comes with short stature, there are four basic steps that you have to do. The first one that is the general look. The second one is measurements. The third one are some maneuvers. And the fourth one that is systemic relevant examination. Whenever you are supposed to do any kind of examination, any kind of approach, the first thing that you are supposed to do that is wiper. What is wiper? Each letter starts for an important thing. The W stands for wash your hands, warm your hands, I stands for introduction and report building. P for position the patient. E for exposure. But you must be beware in case of an elder girl and the ideal exposure in male child that is the shirt off and trousers rolled up. And the R stands for right side to approach for examination. Now, there are four basic steps as I told you, and the first step that is the general look. So, what are you supposed to do in the general look? First thing, listen carefully to the patient's age. Stand back and look for any evidence of obvious diagnosis like Turner and Noonan syndrome, any dysmorphism, any disproportionality which is present in skeletal dysplasias and rickets, any nutritional status, and pubertal status. Now, why is pubertal status important? If there is delayed puberty, that means there is a constitutional delay, pituitary disorder, or some chronic disease. But if the puberty is normal, then that will be familial short stature. Now, here is a child with Noonan syndrome. You can see the widely spaced nipples, the shielded chest, the pointed chin, and here you can see the Turner syndrome, a girl, a short statured girl with webbed neck, widely spaced nipples. So these are the important things that you can not miss in a general look. Step two, then that is of measurements. Now that involves important measurements. The first thing that is the standing height. Now there are basically two things. One is the height and one is the length. When the baby is more than 2 years and he is more than 87 centimeter, you have to measure the standing height. But if the child is less than 2 years or less than 87 centimeter, then you have to measure the length. Now, what is standing height? It is basically the direct measurement of the length from the bottom of the feet to the highest point of the head with the help of a stadiometer. As you can see in this picture, there are two people who are required to measure the height of the baby. One of them placing her left hand on the knees, on the shins and putting them together against the board, and the other one leveling the shoulders, putting his hand on the chins, pressing his head firmly but gently across against the board. This is the way to measure the standing height. Then, in case you have a baby who is less than 87 centimeter, less than 2 years, you will measure the length, but with the help of a measuring board. Here you can see a measuring board. You have to place the measuring board on a stable table, cover the board with a thin cloth to avoid any discomfort. The measurement will be the most accurate if the child is naked, but if the baby is hypothermic or there is cold, so then measure the length with the clothes on. Now, how will you measure the length of the baby? You will measure it that position the child lying on his back on the measuring board, support the head and place it against the headboard, and then what you have to do, support the child's trunk as the child is positioned on the board, place one hand on the shins, straighten the knees, and in this way you can measure the length of the baby. But if there is a child who is more than 2 years, but due to any reason he cannot stand, then you will have to measure the length. So measure the length and subtract 0.7 centimeter. And if any child is more or less than 2 years old and he cannot lie down for measurement, Then measure the standing height and add 0.7 centimeter to that to convert it into length. In short, in order to in this case, in such cases, in order to convert height into length, you have to add 0.7 centimeter, and in order to convert length into height, you have to minus 0.7 centimeter. Now, the second thing you have to measure, that is the upper segment or the sitting height. What is that basically? It is length from the symphysis pubis to the top of the head, or the total head height minus the lower segment. Now this is the sitting height. The height on the scale minus the stool height. You will make the child sit on the stool, then measure the height on the scale and subtract the height of the stool, so you will get the sitting height. Now what is the lower segment? It is the measurement of the length from the pubic symphysis to the floor, or the total height minus the upper segment. See over here, there are different measurements like the sitting height, the lower segment length, the upper segment length, the symphysis pubis, the arm span. The most important thing that you have to measure, that is the upper segment to the lower segment ratio. There are some normal values, and if any baby has a value deviated from the normal value, that will help you diagnose any important thing. At birth, the value is 1.7. At 6 months, it is 1.6. At 1 year, it is 1.5. At 2 years, it is 1.4. And at 3 years, it is 1.3. At 7 years, it is 1. And at 18 years, it is 0.9. Fifth thing that you have to measure, that is the arm span, and then you will subtract the height from the arm span. At birth, the normal value is minus 3 centimeter, which means that the height is greater than the arm span. At 8 to 12 years, the difference becomes 0, which means the arm span and height are equal. But at 14 years of age, the arm span becomes greater than the height. In case of girls, the difference is plus 1 centimeter, and in case of boys, it is plus 4 centimeter. Then you have to measure the head circumference. Wrap the tape around the widest possible circumference from the most prominent part of the forehead, often 1 to 2 fingers above the eyebrow, around to the widest part of the back of the head. Try to find out the widest way and then remeasure 3 times and take the largest number. The seventh most important thing to measure, that is the weight. Step 3 is the maneuvers. Now you have to do some maneuvers from 3 aspects. That first one is while inspecting from the front. While inspecting from the front, there are 5 maneuvers. Hands and feet together, palms up, make a fist, thumbs on the shoulders, arms out straight. Now, the first maneuver is hands and feet together. Now, you have to make the child to bring his hands and feet together. If there is any asymmetry, that will do in Russell Silver. And if there is approximation of the shoulders and absent clavicles in cleidocranial dysostosis, which is basically a genetic disorder. Second maneuver is the palms up. While palms up, you can see a simian crease that is present in the Down syndrome, the Seckel syndrome, then the second thing, clinodactyly, Russell Silver, Down syndrome and Seckel syndrome. Short fingers, that is present in hypochondroplasia, syndactyly, that is present in Alport syndrome. You can see here the simian crease which is present in Down syndrome and the Seckel syndrome. A single palmar transverse crease. You can compare it with the normal. And the clinodactyly, the curved fingers present in Down, Seckel and Russell. Alport syndrome, the syndactyly, you can see the joint fingers. Now the third maneuver, that is a make a fist. Making a fist will show you if there is any short fourth metacarpal which is present in pseudo-hypoparathyroidism, Turner syndrome, fetal alcohol baby, any trident deformity that is present in the achondroplasia, and you can check for the nails, for example, hyperconvexity in nails in Turner syndrome. You can see the short fourth metacarpal that's present in pseudo-hypoparathyroidism, the trident hand, the short stubby trident hands, increased space between the third and the fourth fingers. Now the fourth maneuver, that is the thumbs on the shoulder, Now, if the thumbs overshoot the shoulder, this means that there is the proximal limb shortening, or we can say the baby is rhizomelic. If the thumbs cannot reach the shoulder, baby is mesomelic or acromelic. Over here, your concept of rhizomelia and mesomelia can be clear. In rhizomelia, there is proximal limb shortening. In mesomelia, there is distal segment shortening. In severe micromelia, you can also see there is extreme shortening of all the limbs. In the fifth maneuver, arms out straight, you can rule in cubitus valgus, which is present in Turner syndrome, Noonan syndrome, or any restriction of the elbow extension, which is present in hypochondroplasia. What is cubitus valgus? First, take a look at the normal hand. But if is there any variation of the angle that is more than 15 degree, then that is called cubitus valgus, that is present in Noonan or the Turner syndrome. Then inspect from the side with hands of the child by the side. First, have a look at the head and neck. If there is any prominent forehead, that will be present in achondroplasia. If there is flat occiput, that will be present in Down syndrome. If there is proptosis, then that will be present in syndrome and craniosynostosis. Micrognathia, that will be present in Pierre-Robin sequence. Prognathism, that will be present in achondroplasia. Look at the picture. The first picture is a man with, this is a child with achondroplasia, and you can see the prominent forehead and the prognathism. In the second picture, you can see a baby with Down syndrome with flat occiput, and in third one, you can see micrognathia as present in Pierre-Robin sequence. Then have a look at the upper limbs. If the upper limbs are short, so the fingers may only reach the proximal thigh, and if the trunk is short, then the fingers will reach the knees. Then have a look at the shape of the back, and you can see any lordosis, kyphosis that is present in achondroplasia. Now the maneuvers from the back. So first look at the back. If there's any short neck, that will be present in Klippel-Feil and Noonan syndrome. If there is any neck webbing, that will be present in Turner and Noonan syndrome. If there is any low hairline, that will be present in Turner, Noonan and Klippel-Feil syndrome. Here you can see the short neck in Klippel-Feil syndrome. Then make the child bend over and touch the toes. Over here you can find out any scoliosis if present or wasted buttocks. Then the fourth step, that is systemic examination. First, in general examination, you will have to see nutritional status, hyperpigmentation, any diagnostic features which is present in Turner syndrome, Down syndrome, Klinefelter syndrome, or obesity which is present in Prader-Willi, Lawrence-Moon-Middle syndrome, and Cushing. In CNS, find out focal neurological signs. In hands, find out short stubby hands, polysynthetically, clandectally, clubbing, pallor, wrist widening. In arm, see the radial pulse, the epitrochlean and axillary lymph nodes, the BCG scar. In neck, see the JVP, the thyroid exam, the cervical lymph nodes. Hair and scalp, can find out any the anterior fontanelle if it is wide open, it is present in Down syndrome. Find out the scalp hair. Noonan syndrome has some risk like hair. In eyes, see for jaundice, pallor, bitter spots. In mouth, see any repeated evidence of any repeated cleft lip or palate dental assessment. And then while lying on couch, first examine the chest, auscultate the heart timing with carotid, auscultate the chest or any deformity. In abdomen, palpate the liver, the spleen, the kidneys. In genitalia, seek permission first and then examine. In legs, find out any vital edema, and in vitals, apply the and GP measure all the vitals. Now, what will be the differentials? So, whenever a baby comes with short stature, you can divide them either. It will be either proportionate or disproportionate. In disproportionate, there are three diagnoses. It will be either rickets, hypothyroidism, or skeletal dysplasia. But in proportional short stature, the diagnosis, the differential will be constitutional, familial, malnutrition, chronic illness, syndromes, endocrinopathies, or psychosocial deprivation. Now, what will be the investigations? You can go for bone age, CBC, ESR, RFTs, anti-TTG, hormonal study, skeletal survey, TFTs, calcium profile. Now, bone age x-rays are important, but at birth, what x-ray will you advise? You will advise any x-ray. In children less than 7 years, you will advise the wrist x-ray. and more than 7 years, you will go for an elbow x-ray. So here it comes to an end, and I hope you are clear how to approach a child with short stature. Thank you.